disclosure, where I work. Well, you all know the anterior approach to the cervical spine. I'm not going to talk too much about it, but even this very standard approach, which is safe, which is nice, which is MIS, it has some limitations. Especially for me, the problem are the retractor blades. The retractor blades are pushing on the soft tissue, and you get postoperative dysphagia, dysphonia, hoarseness. And if you take out too much, you create iatrogenic instability. So many times you have to put in a cage. There are many publications talking about patients with dysphagia, postoperative dysphagia, up to 20-30% of patients. 10% of the patients may get severe dysphagia lasting over a year, requiring referral to an otorhinolaryngologist. So it is an issue. It is an issue that is there, even though it is a very widespread and safe approach. So there is a way to go with the endoscopic approach. The advantages are that you get very good visualization, especially of the posterior end plates under continuous irrigation. You get less bleeding because there is less dissection, and you don't use retractor blades. So the risk for postoperative dysphagia, dysphonia, hoarseness is decreased. Okay? And of course, being ultra minimal invasive, you get less iatrogenic instability. Okay. So usually when it's just a herniation, you can think about doing just a discectomy. You can put in a cage or not, you will see later. So this is a typical case. This is a patient that came in with myelopathy, as you can see here. It's tight on the dura, strong guy, almost no neck. So you go anteriorly. I will show you later how I do it exactly. And you do the soft tissue shrinking, you do the annulotomy, you open up the annulus, and you see that it's a very clear view. It's a very clear view, but the nicest thing about this technique is the view that you will get of the posterior part, which is always the tricky part to do. You can use your usual tools. You can use the high-speed burr to take out the anterior ossifieds. And let me see if I can skip this a bit forward. Oh, what did I do? Oh. Can I use this to skip this forward? Because otherwise it will take too long. How can I do this? So that I can use the, no, it doesn't work. They kind of did the two-screen thing in another. Yeah, exactly. Yeah, that should work. Okay, thank you. So this is when we get to the posterior part. Okay, you can see I can get into the canal, remove the posterior osteophytes, and you get a nice clear view of the canal. And then you can start to uncover the dura, which you will see appearing here now. Okay. So I'm removing the PLL. Oh, what did I do again? Oh no, come on. Oh, sorry for that. This is a bit tricky. So removal of PLL, here you have the dura, okay? And you can do a very, very nice decompression under constant irrigation and under view, okay? So this is the preoperative, postoperative. You can see very nice decompression endoscopically, and this is pre-op, post-op. This was 3 months after surgery. 2 years after surgery, you still can see the canal is decompressed, the patient is doing well. So it's a very nice endoscopic procedure that I like to do. And there are some publications out there saying that the rate of complications is very similar to posterior, so it works well. There are things that I didn't like about the way I was taught this technique, especially the annulotomy. The way the Koreans teach it is that you do a percutaneous annulotomy with a crown reamer. And for me, that was always heart-stopping. My coronaries didn't tolerate that. So I kind of modified the approach to what I believe is a bit safer, and I'll show you how I do it. So this is a male, 64 years old. He came in with bilateral paresthesia, neck pain, but what he had is ataxia and a positive Hoffman test, so clear signs of myelopathy. Okay, so you can see the Hoffman test here, and in the imaging you will see the compression of the spinal cord. which you have here, okay? No OPLL, so not super complex in that sense, okay? Some posterior osteophytes. So, yeah, so I thought, okay, let's do this endoscopically. How do I do it, right? So first of all, it's very important that you put in a reinforced tracheal tube and that you put an nasogastric tube so that you will actually see on the X-ray the trachea and the esophagus. So this is just what they call the stabbing, so you have to be careful with that, but it's exactly the same way that you would do the open approach. You can see here the displaced esophagus and trachea, so I know exactly where they are. You can feel the pulse of the carotid artery, so this should give you a safe approach to there. Then I use the K-wire, okay, and then small incision, and then I start with a small dilator. Okay, here we go. I always check that I'm fine on the X-ray, and you can see again. You can see the. I always have an idea where my different vascular, esophageal, tracheal structures are. So I keep on dilating, you know. Then I have a nice soft tissue dilation, and then I put in the screw. Everything is guided. Everything is anchored to the disc, so there's no slipping. And once I have my endoscopic sleeve in there, I know that I'm protected by the sleeve. Whatever I do, I'm doing it inside the sleeve. So this gives me a safe space to work in. So the thing that I modified compared to the approach I learned is that I'm doing the reaming, the initial anulotomy, I'm doing with endoscopic view. So this is the crown reamer. It's being inserted guided by a dilator under endoscopic view and protected laterally by the sleeve. So I have a three-step protection, if you want so, for the first reaming. And this is usually the critical step for this approach. Because once you have done the anulotomy, you have a visual landmark that will guide you through the rest of the procedure. Even if you slip, you will be able to find this space, okay? So, and once you have done the anulotomy, you're done. You have the point where you want to start, and then off you go, okay? Because the problem I had, if I slipped, then I had to restart again. This way, I know where I am, I know what to do. And the rest, you already saw the other case, it's exactly the same. You just go on, do the decompression, the patient is doing well. I just published this surgical technique in Neurospine. It's going to be published in December, a special issue. So, of course, discectomy is not always useful. So what you need is actually to put in, oh sorry, I didn't show you that, and that was also in the video, the part where I put in a cage. So to put in a cage, what I do is after I have finished the decompression, we designed some special blades that we put in with a dilator. So I put in the dilator, I take out the sleeve, and then I use these specially designed blades just to slip them in. And then I just open it up with a retractor. Very simple, but this way I don't have to do any dissection to place the cage, okay? So I just open up, and then I have my workspace. I have the disc exposed, I have done my discectomy, that's it. And now, using the fluoroscope, I can place the cage. Usually I use the zero profile cages. I can put in the screws, okay? And then you have a small skin incision that I need to do because of the cage. Patient didn't have any dysphagia, any dysphonia, and the cage is sitting right. And when we compare, I did a 1-year MRI, and you can see the decompression of the canal in the axial view. So the patient is doing well, and no ICU, no bleeding. Okay. So just very quickly, some case presentations. Patient with this highly migrated herniation, okay, that you have in the canal. So I did here a endoscopic decompression, 2-level fusion. This was one of my first cases. I didn't put in screws. That was the last case I did standalone. And you can see here 2-year follow-up, and you can see that the decompression of the canal, okay? So preoperatively, there is still the herniation migrated, and the canal is free now. So this patient, also with anterior osteophytes, it's not a contraindication. You can still do the technique, get in there, burr out the osteophytes. You have a 2-level ACDF, okay? This is usually how it looks like. 91 years old patient. She's 91 years old, similar case, okay, degenerative disc disease, and I did a 2-level fusion, okay, and this is with 91 years old. This was 12 hours after surgery. I'm finishing right now. Sorry, that was the same evening of the surgery, and then in the next morning, you will see her walking now the next morning. With 91 years old, I am feeling well doing this on a 91 years old because I know that my footprint will be very, very small. It's very little invasive, okay?
Dr. Krishnan, please
yes,
summarize.
I'm finishing. So basically, this is it. This is the idea. And limitations, of course, fluid arthrosis. If you have vascular limitations, then you have to open up, put in a plate. You can't do that with endoscopy. That's the idea behind it. Patient that had a tumor, I had to go open. So there are limitations, okay? So in conclusion, I think it's safe, I think it's reproducible, I think it's doable. So that is my idea of doing endoscopic anterior cervical discectomy and fusion. Thank you very much.